Hello, my name is John Fleck, and this is my case connection number 4, where I will present case 3 and case 4. So, case 3 is about a 47-year-old man who presents with severe right great toe pain. This is after no apparent injury, no known trauma to the site, and he reports that the pain started suddenly and has gotten worse since then. It's been about a day since it started. So based on his physical and laboratory findings, the patient is diagnosed with gout. And gout is described as a disease that causes acute joint pain that is caused by an accumulation of uric acid that precipitates in the joint spaces. This patient has, in case 3, had a complete blood count performed and urinalysis, which showed elevated plasma urate levels and decreased uric acid levels in his urine. So in other words, his blood showed increased uric acid levels, but his body is not able to get rid of it appropriately, so it's decreased in his urine. So these results are consistent with an overproduction of purines. This clinical presentation presents as a result of a deficiency in the enzyme glucose 6-phosphatase, which is a hallmark of type 1 glycogen storage disease or von Gert's disease. So this top portion up here on this side of the squiggle is a schematic of von Gert's disease. So under normal circumstances, glycogen is converted to glucose 6-phosphate, which via glucose 6-phosphatase is converted to glucose. So under a condition where a patient has von Gert's disease, this enzyme is not working appropriately, causing glucose 6-phosphate to instead become ribose 5-phosphate via the pentose phosphate pathway, which then becomes uric acid and causes gout. So it might be suspected that an increase in urate levels in the plasma would also increase uric acid levels in the urine. However, this is not the case with von Gert's disease. Instead, it is hypothesized that that von Gert's disease causes a deficiency in the URAT1 transporters in the kidneys. So in other words, uric acid builds up in the blood, but is not able to be disposed of properly via the kidneys. So some other differential diagnoses because suspected with this patient derive from a deficiency in purine salvage as well as a decrease in urinary excretion. So patients who are experiencing a deficiency in purine salvage typically present with increased levels of both plasma urate as well as urinary uric acid output. Patients who present with that typically would be diagnosed with Lesch-Nyhan syndrome. So we are dissuaded from making this diagnosis again because the patient had decreased urinary uric acid output. Lesch-Nyhan syndrome is characterized by a deficiency in the enzyme hypoxanthine guanine phosphoribosyltransferase, or otherwise known as HPRT. Deficiencies in this enzyme result in an accumulation of hypoxanthine and guanine, and excess accumulations of these nucleobases are converted to uric acid and accumulate in the blood and cause gout. So again, under normal circumstances, these two nucleobases here, guanine and hypoxanthine, are converted to GMP and IMP, respectively, by HPRT, the enzyme at play here. Under conditions where a patient has Lesch-Nyhan syndrome, HPRT is deficient, causing hypoxanthine and guanine to instead be converted to xanthine and then later to uric acid. Down here, see an increase in uric acid. So this diagnosis, again, would not cause a deficiency in URAT1 transporters of the kidneys, so there would be an increase in uric acid output. So additionally, it's possible that this patient could be experiencing a deficiency in urinary excretion of uric acid. This diagnosis, however, is not suspected because the patient did not mention any excessive alcohol consumption, which is typically required for this. So the patient should be asked to specify his dietary intake history for a clearer understanding in order to potentially make this sort of diagnosis. So after further discussion, talking with the patient, it is found that he has been consuming 4 to 5 liters of soda a day, which is an enormous amount. The primary sugar in soda is high fructose corn syrup, and this patient's extreme fructose ingestion likely contributes to the development of his gout, as fructose is implicated in purine synthesis. So following consumption, over here, so this side over here is fructose metabolism. Following consumption, fructose induces the production of uric acid in the liver by increasing AMP levels from ATP. AMP is a precursor to uric acid and therefore increases uric acid levels upon consumption of fructose. So again, up here, fructose right there is converted to ADP and fructose 1-phosphate. ADP is converted to AMP, and AMP is a precursor that would eventually increase levels of uric acid. And uric acid increases, like I mentioned, would increase the prevalence of gout. So, case 4 details a 58-year-old woman who presents to an emergency department with progressive fatigue and weakness over the past couple months. So recently she's short of breath, and upon review of symptoms has diarrhea. She has intermittent numbness and tingling over her lower extremities, and loss of balance also while she's walking. So she's also experiencing some tachycardia, as well as a swollen red tongue and systolic murmur. She also presents with no depression, but has a low hematocrit count and megaloblastic anemia is suspected. So this patient is likely experiencing a deficiency in vitamin B12. Vitamin B12 is otherwise known as cobalamin and is an essential cofactor in 2 reactions. First, it is required for the remethylation reaction, which converts homocysteine to methionine. Methionine is an essential amino acid that is converted to the intermediates of SAM and SAW to eventually synthesize homocysteine. Homocysteine may then react with folate and cobalamin to reproduce the amino acid methionine. So deficiencies in vitamin B12 in this cycle prevent homocysteine from being converted to methionine and result in a condition called hyperhomocystinemia. Accumulations of homocysteine are associated with increased risks of cardiovascular disease, as well as pyrimidine bases being unable to be synthesized. So decreased pyrimidine synthesis results in reduced hematopoiesis and eventually leads to megaloblastic anemia. So this little schematic here details the reaction that I just talked about. So this is a vitamin B12 deficiency. Again, homocysteine is converted to methionine with the use of B12 as well as B9, which is folate. In a situation where B12 here is deficient, this part of the reaction would be unable to take place. So we would accumulate homocysteine over here instead of, and methionine would decrease. So the second reaction that requires cobalamin is in the synthesis of succinyl-CoA. A lack in vitamin B12 results in the accumulation of methylmalonic acid, or otherwise known as MMA, and high levels of MMA contribute to myelin degradation, resulting in neurological damage. So this sort of neurologic damage likely contributes to the decreased sensation to touch and vibration that this patient is experiencing. So this patient is likely not experiencing an iron deficiency. Iron is required by the quaternary structures of hemoglobin in the blood to carry oxygen. So while lethargy and weakness are hallmark symptoms of iron deficiencies, neurological impairment is not. So she likely does not have an iron deficiency. A vitamin B6 deficiency is also not suspected because of the clinical manifestations that the patient is experiencing. So vitamin B6 deficiencies would result in neurological symptoms in conjunction with the swollen tongue that this patient has. However, depression is a hallmark symptom of vitamin B6 deficiency. Again, vitamin B6 is otherwise known as peroxidyl phosphate, which is a requirement for transamination reactions, such as that from tryptophan to the neurotransmitter serotonin. In a situation where B6 is not available, tryptophan cannot be converted to serotonin, which would increase the prevalence of depression. So because this patient has no depression noted, it is very unlikely that she is experiencing a vitamin B6 deficiency. So microcytic anemia is another common symptom of both iron deficiency and B6 deficiency. She is not experiencing microcytic anemia, so that also helps us to rule out those two causes. So laboratory tests that should be run to confirm this diagnosis would be a CBC and a peripheral smear. These tests would allow her care team to identify levels of molecules in her blood that may be low, as well as microscopically examine her tissue for abnormalities. Thank you.